Good afternoon. All right, so I'm going to start this off just doing a little bit of a history lesson, but I have to make that statement. I have no financial relationships or commercial interests to report. And I'm going to use my career path to explain how I didn't choose the population chose me. Then we'll get into part of what Louisiana's doing with the Louisiana State Opioid Response, give y'all some understanding about that, and SBIRT. So I actually started off, I was in business before, then started working as a hospice chaplain. And what does that have to do with the looking at the opioid epidemic? This would have been about 2003, 2004. I was working as a chaplain, working closely with a social worker. And when you're looking at hospice at that time, a lot of pain management going on, a lot of prescription of and administration of methadone, oxycodone. When a person is on hospice, for the nurses in the room or people that are familiar, at that time they brought them morphine to have in the refrigerator. I mean, there was just pain medications, benzodiazepines, a lot of medicines in the house. So I didn't really see that as an issue because I'm there as a chaplain. But working with the social worker and began to address some of the problems in the family. With those issues that began to come up in the family with medicines coming up missing. Requests for more medicines. Watching some of the patients that were ambulatory, able to take their own medications, make a mistake in taking medications and see them in a very bad spot. Very difficult population to work with, takes a lot of self-care. That was part of my role as the chaplain, not only giving direct care, spiritual support, but was also there for the team. So one of the roles of the chaplain is really to connect the patients with outside resources, connect them to the local church or the resource that they have, and give them that support while the palliative care is going on. I was having good outcomes with the patients and their families I was working with, so the social worker invited me to come and work with him. He had a halfway house. They did IOP as far as a halfway house for people coming out of residential treatment. What you notice in that setting was same thing. This would have been around 2005, about 2005, 2006. The Access to Recovery grant was active at that time. And with the Access to Recovery grant, it was for the underinsured and uninsured. And a lot of the patients I'm working with at that time were taking hydrocodone. That was the primary. As things moved on, got recruited to go work within the criminal justice system. Now we're coming to the emergence of oxycodone. A lot of issues with addiction at that time, not so much on the standpoint of overdose, but we're emerging in that way. What I can tell you, some of my last work, I've been working with LSU since May. Prior to that, mainly focused in the criminal justice system. I watched in the past 18 months to 2 years where I was doing assessments for people to enter into certain type of programs, whether it was pretrial intervention or adult drug court, different programs that they might want to go into. You might have 1 to 2 people that say they were doing IV substance use. You might have, every now and then you had someone that might have reported an overdose. In the last 2 years, it got to the point to where about between 7 to 8 out of 10 people that I would assess were actively using either heroin or some other type of opiate. And there's another trend that's not really covered in what we're doing right now in this response. There's a very rapid trend of people doing IV methamphetamine. Don't know exactly why that's emerging. I can just tell you that's what's coming up in the assessments. So started off in the medical, right back down, we're now doing the work with the LaSure project, back integrating with the medical field. What's nice and refreshing about that, working in hospice with the interdisciplinary team, you're sitting at the table with everybody. It's the social worker, it's the chaplain, it's the pharmacist, it's the nurse, it's the doctor, it's the specialist. Everyone sits around the table with those varying perspectives with one primary goal, and that's to help that patient that's involved. So Louisiana State Opioid Response has various parts. The part that we're associated with is being administered by Louisiana State University, LSU Health Sciences Center of New Orleans. The overall goal of the LeSueur project is to increase access to medication-assisted treatment for opioid use disorder and reduce opioid-related overdose deaths with focus on under and uninsured populations. The services offered are MAT treatment, MAT, clinical consultation, Narcan kits. Another just tidbit to give in the development I was doing those assessments over the past couple of years was that it went from having an overdose and someone talking about they maybe made it to now we're starting to see people who've had multiple overdoses. It's not uncommon for somebody to tell me that I've overdosed 2 to 3 times and I'm having to ask them, when was the last time? When was the most recent? And it would be like, yeah, the day that I went to jail. That's the last, when I overdosed. I was saved in this way. And then now we're trying to work to see what do we do at that point. One of the challenges, and we'll talk about that in the levels of care, when a person goes where they're in a controlled environment, when they can lose some of the tolerance they had to the substance. They're going away for 6 months, 9 months. They come back and think they can do the same amount that they were doing before. And then when they left, they were doing oxycodone, maybe a little bit of heroin. And now they run into fentanyl, and that's it. I mean, the person overdoses. Now, I think it's important to be honest, with everybody in the room. If you look in the early 2000s, 2005, 2007, learning about addiction treatment, it's a little bit apprehensive about medication-assisted treatment. That wasn't the common thing that was being trained on, wasn't as acceptable, and there was a lot of stigma involved. When they started having some changes where clients, it wasn't medication-only treatment, they began to be recommended or to be compliant, they had to receive some type of services. I started receiving phone calls at the agency saying, hey, will you see me? I'm receiving this medication for opioid use disorder, and if I don't get a counselor that's going to see me, I'm not going to be able to get my prescription. The first time I thought it was a fluke, like, oh, okay, that's just somebody saying that. It's not something I specialize in, but that's not something I want to take on because I haven't had the specialty. I wasn't sure I could help them in the right way. Then we got another call and another call, till finally it was a consistent thing. So I went and started doing some training. This was back in about 2008 to about 2011. 2012 is when I took, I'd say, my first client that I worked all the way through. And when we're going to look at some of the things we do with referral to treatment and some of the stigma we're still dealing with now, I dealt with stigma in 2012, 2013 when I took on this particular client. Client was in the criminal justice system, involved with DCFS. There's some other things going on. They weren't allowed to receive services with everybody else. So if I didn't agree to see that client was not going to have access to services, which might have put them at risk to not getting the custody of their children back. Like, so what do you do? But me as a practitioner doing that, and the stigma that was associated at that point with someone being on buprenorphine, that's another issue, because it puts you at odds sometimes with other practitioners that were out there. Good thing I can tell you is, and I guess it was just by faith or by chance, I talked to one of the best friends of that person a few days ago, still doing well. The child is doing well. Actually, the child just graduated. The family's still together. So those outcomes, it does work. But I can tell you, it took a lot of courage on my end, and as well as the actual patient to engage at that time. This particular patient knew that if they got off of that, they had not seen any type of good sobriety before being on medication-assisted treatment. And they were scared that if I get off of this, I'm just not going to make it. So, in looking to enhance and expand the capacity of OUD treatment by working with various organizations and deliver medication-assisted treatment. And the way we're doing this is implement a collaborative approach by delivering MAT, facilitating access to medical and non-medical supports. And Louisiana is using a similar model. It's a little bit adapted from the Vermont model, which is the hub and spoke model. So I'm going to go over with you guys some of the aspects of the hub and spoke model. And at the end of the presentation, there's a link, and we'll try to go ahead and put it up there. Department of Health now has a site up there for all of the office-based opiate treatment centers that are part of the grant that are contracted. Now you can look them up for yourself to see which ones are in your area. And so as they're contracted, they're making them available. hub and spoke model. So the actual hubs is the OTP, the opiate treatment programs. When you see OTP or hear opiate treatment programs, these are the methadone clinics. Though there's 10 in the state of Louisiana, they are part of the LASOR grant as well. Just to give you some understanding, OBH, Office of Behavioral Health, has the LASOR grant. They're contracting some things directly with certain aspects. LSU has the contract with the Office of Behavioral Health to do the actual hub, the spoke model, as far as doing the spoke care teams. So what is the spoke care team? It's a licensed mental health professional and an RN who work together as a team, who then go in and provide support and services with either FQHCs, private hospitals, outpatient providers, psychiatrists. And in one of the previous presentations, you heard talk about the waivered prescribers. All right. So as you're increasing access with waivered prescribers, let's say it can be a psychiatrist's office, it could be at a local, say, family physician's clinic. They're not always going to have access to the behavioral health support or the experience needed as far as from the nursing staff to be able to address the clients that would be on buprenorphine or one of the other substances for medication-assisted treatment. In Region 4, we have our first clinic that went active. We went there on yesterday. We haven't taken our first patient yet, but we are happy to say that we've actually started in the area. We have 2 more that should be coming on board within the next couple of weeks. And there's several active within the state of Louisiana. All right, so each spoke care team, we're employed by Louisiana State University, and then we go into the different OBOTs, as we call them. So when you see the office-based opiate therapy, just OBOT is what you're gonna hear. So if you've been working in behavioral health or anywhere else, it's all about some type of acronym and some kind of new word. So OTPs, OBOTs, we're called spoke care teams, we're called SCAT teams. There's some stuff with the Office of Public Health. They're called OPOCs. So there's all kind of brand new names you're gonna be hearing. So begin to learn the language. With the Louisiana State Opioid Response, these are the things that you're gonna hear when talking about it. So if someone says it's a SCAT team, well, it's someone like myself and Marcel, it's a LMHP and an RN who's actually doing care coordination, going into the actual prescriber's office, collecting data, doing screening, and also making referrals as necessary in order to give the best recovery support services needed for that patient. All right, so the teams will be located throughout the state in each one of the 10 LGEs, the local government entities. And within each one of the LGEs, there'll be 5 actual OBOTs. So there'll be a total of 50 throughout the state. Yeah. All right, and so we mainly act as a liaison between the OBOTs, the OTPs, and other LASOR provider networks. We do screening, brief intervention, and referral to treatment services, clinical assessment, case coordination, recovery support, and data collection and entry. Before we get into the SBIRT, let's talk a little bit about levels of care and why this is very important for integrated treatment within the state. I've worked in different systems. I'm gonna call them all silos, kind of pulling off the business background. When you work within the criminal justice system, that's an ecosystem all by itself. When you're working within the criminal justice system, often when someone goes to see a medical professional, a doctor, someone in that way, it's a little bit, can be a little nerve-wracking, because if that patient who's now in their world is called an offender or participant, or depending on what the language is being used, they might be asking you to send reports and letters and make determinations that can be a little bit concerning sometimes in doing that. But it's very much needed. In the criminal justice system, I can tell you that they have now, for the past 3 years, been embracing medication-assisted treatment. Actually, there's been some, it's been tied a lot to funding. If you are going to receive certain types of funding, then you have to offer medication-assisted treatment. So one of the core components we're going to be using as part of the LASOR program is SBIRT. Put this up there. SBIRT I was part of another grant with LSU Baton Rouge, And what that was a trainer of trainers grant. What we were doing a few years back was going into hospitals, clinics, also going to schools, doing trainings for nurses, doctors, other support staff. And the goal was to create a screening process to do early identification. The good part about this, as people are learning SBIRT, similar to what Mr. Arsenault was just talking about, we want to help those that are struggling right now with opioid use disorder. But we also want to develop a way that we can do earlier identification and get individuals the support and help they need so they don't have to develop a severe opioid use disorder. SBIRT is one of the ways that that can happen. One of the challenges when that grant was being implemented was, well, good, how are we going to make that work? So you've exposed us to this thing that could potentially work. Who's going to fund it? How will it work? How can we implement that into our practice? Well, with the LASOR grant and with us as the SCAT team, we have now the opportunity to take that SBIRT training and other trainings that we've had and bring it to the actual practitioner's office. A lot easier for them to implement a program working with clients with opioid use disorder when they have the proper supports. If anyone that's been working in addiction for a while would know that sometimes it's a little tricky in making referrals. If you don't know the exact paperwork you need to send, and if you don't know the exact person to contact, if one piece of paper is missing or you're missing a certain amount of things on the referral form, guess what? Client gets no access, patient gets no access. With us being in there as a SCAT team, we'll be able to help to bridge that gap, work with them, educate the providers and the clinics on what resources are available, as well as make some of those direct referrals for them to get the recovery support services that they need. So what does SBIRT, that acronym, stand for? It's screening, brief intervention, and referral to treatment. So SBIRT is a comprehensive integrated public health approach to the delivery of early intervention and treatment services. It is used for a person with substance use disorders, those that might be at risk for a substance use disorder, or some that would be diagnosable with a substance use disorder. The screening, we use universal screening tools for quickly assessing use and severity of alcohol, illicit drugs, prescription drug use, misuse, and abuse, as well as mental health problems. If you go to a couple of the presentations this morning, you remember that the data showed that anxiety disorders, depression were very common on clients that have opioid use disorder. Well, the two instruments we're mainly using for screening are the GAD-7 and we're using the PHQ-9. And PHQ-9 gives us a way to screen for depression. The GAD-7 gives us a way to screen for anxiety. The referral to treatment part I'll cover towards the end, and that's I'll spend a little bit more time on that. I want to make sure we can get to that because there's certain challenges and stigma that goes along with trying to make referrals for a client that's on buprenorphine. You got to look at philosophies of treatment. You have to look at what type of access and how are you going to get them all the recovery supports they need based on what's available to them in the community. Primary goal of SBIRT is to identify and effectively intervene with those who are at moderate or high risk for psychosocial or healthcare problems related to their substance use. In doing the whole SBIRT training, there's an overview, what it's used for. There's actually an implementation module where you actually train to be able to use SBIRT. It goes in the history of how it was used as a moral failure, how it was used as a criminal problem. Well, criminal justice problem. With the SBIRT approach is seen from a public health perspective. It's a brief and highly adaptive evidence-based practice with demonstrated results. It has been successfully implemented in diverse sites across a lifespan, and patients are open to talking with trusted helpers about substance use. Some of the data, when you go through the full SBIRT training, it's similar to some of the data that was discussed earlier. There was a thought that if a person had a substance use disorder, opioid use disorder, even an alcohol use disorder, that if the doctor or the practitioners in the doctor's office would ask about it, that they wouldn't be willing to tell them. What the study showed was that it was just the opposite. They were more likely to tell their medical professional, some of them even telling their family or other close people that they had in their lives. So it's a great place as far as when you have a relationship with an actual patient that's coming to that clinic on a regular basis to be able to screen for these potential substance use disorders. Patients are open to talking, and ESPER makes a good clinical and financial sense. If you can identify them early, get the brief supports that they need, then you could maybe catch it at a mild to moderate level rather than allowing for it to be severe. For those of you guys been doing this for a while, I remember parents calling me saying, I need some help for my child. So we go through the whole process, we go through it. It's been the early 2000s, maybe 2008, I guess around the middle point. And I remember it's like the only way I could probably get your child some help right now, based on the resources you have, is if they were in trouble. If they were in trouble in some type of way, or danger to themselves or others, they were skipping school, runaway, if there was some ungovernable, unless they were in some type of way causing a serious problem, they didn't have good access. When I worked at the sheriff's office, it's an adult facility, there's no juveniles. The current sheriff at the time I was working there, we started 2 to 3 juvenile programs because there just wasn't enough help for the juveniles. It seemed kind of weird that the actual adult jail would be providing juvenile services, but there was such a gap in services, we knew we had to do something. And so we had a leadership and resiliency program that went directly into the schools. The Milestones program would dealt with outpatient adolescent mental health and substance use. We did functional family therapy to try to see what we can do to make some intervention there. And this was all done by the criminal justice system. And so that was another thing when I left working in that capacity in the criminal justice system, our continuum of care had grown so much, but there was a lot less of a continuum of care on the outside of the justice system. So I actually resigned and started working towards helping to build more resources in the community to balance things out. It was the same thing. A person could get in trouble, right? And DOC, Department of Corrections, being funded. You can go get the help when you're in trouble. You can get access to vocation, substance use help, mental health, all of that. All you have to do is get in trouble. All right. So working at the jail, you can go do a lot of the research on that. When people were struggling with severe mental illness and there's a lack of capacity for inpatient units for people with psychiatric disorders, where do you think they are? Yeah. One of the saddest trips I made was going to Angola and a couple of other prisons, is to see what it looks like when they actually go to prison long term. And even working hospice, as tough of a job that was, it didn't prepare me for what it would be like when I went to Angola and watched prisoners on hospice and understanding, and this is the thing that really struck me, they had been so disconnected from their family for such a period of time, these people, even in death, would not leave that facility. No family was going to claim them, so they were going to be buried on the facility. And that's how it ends. We don't think about that because it's not in our normal social interactions, but when you're there and you get a chance to try to wrap that around your brain, it's really tough. And you get to see that this is the end result. So on how does substance use disorders, what drew me into the criminal justice system was nothing to do with the fact that I wanted to work in the criminal justice system. When they first recruited me, it took me 6 months before I showed up to my first day of work because I couldn't see myself willingly and knowingly agreeing to go behind bars for 8 hours a day. It just didn't make sense. Well, what I found when I was working at the outpatient clinic, at the private clinic, was that I'd have clients showing up, and all of a sudden they would just disappear. I'm like, man, Johnny was doing so good, right? They've been coming. It's the first time they've been clean for 90 days in their life. They're talking about all these great things, and then they would just disappear. Well, they might not have been paying their probation fees, some other things, and they would just disappear. I realized that I was handicapped. If I didn't have some kind of integration with the criminal justice system, I couldn't effectively help my clients that I was getting. You look at underinsured, uninsured people with low socioeconomic status with a substance use disorder, criminal justice involvement, there's a high likelihood that they would end up in not only jail, but end up in prison. They don't end up in prison for the nonviolent offense right up front. They take a plea and they sign to probation requirements that they can't fulfill. So I'm a person that I committed an aggravated assault. first offense. I just randomly, just really beat someone up, very violent offense. When I go on probation, do they drug test me? I didn't screen at all for having an actual substance use disorder. It's not a risk factor, right? So no drug screens. Well, I get arrested for possession and have a known substance use disorder. What happens when I'm on probation? I'm drug screened on a regular basis. Well, that's a probation violation waiting to happen. And so that one probation violation, that technical violation with that, add one other thing of noncompliance. That person now, that time that they got on probation, they're about to go do all that time in prison. So why I'm bringing this up is that when you see about making referrals, and one of the special populations with the Louisiana State opioid response is the criminal justice population. Criminal justice population has been actively using Vivitrol as far as, and there's some things going on at Angola and some of the reentry processes that they're working towards doing medication-assisted treatment actually in the prisons. Second special population is dealing with pregnant females. That is another thing I'd prefer, and then divert to let medical professionals talk more about that particular population. But when you're looking at a pregnant female who is actively using opiates, there needs to be some good intervention. So these are two populations that we'll be focusing on with the LASOR grant. And again, I've been in practice for a while. I remember one of my clients coming in who was actively using opiates, and it's a mandated report, right? So this was before it really started progressing. This was probably about 2011 or so. So I call and I make the report, and what do you think happens? They tell me that, well, until the child is born, there's nothing that I can do. So I start calling around, looking for resources. What can I do to get this person some help? She wants the help. It's progressed quite a bit now. There's quite a few prescribers who will take that pregnant female and walk them through to a successful birth with that child and give them that dignity and really increase the chances for that child to do well. There was one hospital, after calling several within the state, that was willing to take this person to help her out. And the challenge, what they said, and it's a real challenge, it's not to throw shade in any kind of way. It was like, what kind of resources it takes? She was far on in her pregnancy to keep this person monitored and managed, and what that was going to be for the hospital, uninsured. So it was a real issue. Who's going to pay for that? That's often the question. All right, so screening. Screening is the first step in the expert process, and it often precipitates patient self-reflection on substance use behavior. When we're doing a screening, we're not looking to provide a diagnosis, but it does determine the severity and risk level of the patient's substance use. One of the alterations with the expert that we're doing with the LASOR project is we're also doing what's called a treatment needs questionnaire, and that helps to determine on a screening basis, would that person be better seen at an OBOT? Maybe they've received something like buprenorphine, or is that person at a severe level that may be better treated at the opiate treatment program? They might, looking at methadone, and use some clinical judgment and then do some further assessment, working with the OBOT to see what would be the best level of care. Brief intervention is a brief motivational and awareness-raising intervention given to risky or problematic substance users. Brief intervention with a brief negotiated interview is a semi-structured interview process based on motivational interviewing principles. It can be completed within 5 to 15 minutes and is backed by extensive research indicating its effectiveness for facilitating positive health-related behavior changes. When a provider, let's just say your general practitioner, if this is implemented in their office and there is enough good referral sources for them to access, that 5 to 15 minutes can be the thing, because as a trusted person they know, where they can raise consciousness of where things are and accept a referral and move towards getting some help. A lot more effective than some of the other ways, like again, them getting in trouble. And I will say that, and I echo what Scott has said about the advancements in the criminal justice system. There's many interventions that are set up now that people are not getting arrested so quickly for use. Addiction is considered, a disease by the World Health Organization. It's one of the only diseases that you can have that once you're addicted, if just to keep, how can you effectively continue with that addiction without breaking the law? If you don't have a prescription anymore, how do you get the substance? Buying the substance, transporting the substance. I can go down the list. It's very difficult to not get involved in criminal activity, but that doesn't mean that that person is a criminal. All right, motivational interviewing techniques. In the context of a collaborative conversation, you use MI strategies to facilitate finding personal and compelling reasons to change, building readiness to change, and making a commitment to change. And this again echoes the presentations this morning, talking about the theory and the research being done that motivational interviewing, cognitive behavioral therapy, start talking about these treatments that are shown to be on the front line, what are shown to be effective in 2019. Notice with the Louisiana State opioid response, this is where we are. If you do an SBIRT, part of doing SBIRT is to be trained and be able to effectively do motivational interviewing. This is going to give us better outcomes, especially coupled with appropriate prescribing of medication-assisted treatment. And one of the things I always like to point out when it talks about, making a commitment to change, if you're looking at motivational interviewing, you're also going to learn about the, dealing like the stages of change model as far as looking at addiction. Whether they're in pre-contemplation, contemplation, preparation, action, or maybe in an actual relapse state. But often what you're doing at that point is you're trying to elicit change talk, get that person to talk about what they feel is important. I have learned so much about what is going on in the Lafayette area, and who you think is my best teacher? My clients. When people start talking about dabs and vaping and all that stuff, but really about the dabs, many of you, and I thought Scott was going to touch on it, and I told him I was going to bring up that one point. With I call it the marijuana or cannabis delivery system with some of the vapes, you can have a client you can have your child sitting next to you in the living room and vape and actually be taking in cannabis, and you won't smell it. It'll be right here on the side of you, and you wouldn't know any different. And they'll start using this language, having this discussion, and they can be having this discussion right there in front of you and the rest of the family with others that understand what they're talking about, and you would have no clue what kind of discussion that they were having. So it's unfortunate we're starting to see some predictions that it was myself working with some clients that due to the technology of drugs, that we'd probably see some cannabis-related deaths. Now, that's not a term, it's a term that between myself and the clients we came out with, it's the technology of drugs. Cannabis by itself, you would have to smoke so much to get X amount of THC. In those dabs, they can do an extreme amount of cannabis with that technology. So now they're taking in a level of substance they couldn't do on their own. And they're not just going to do with cannabis. As we are looking at this opiate epidemic, we have to be vigilant and watch and really learn. If you can establish a great relationship with your patient, your client, once they get to that point where you got the change talk and they want to change, they will be more than happy to share with you what are their real challenges. Because when you're saying, oh yeah, you don't have to worry about it, you just have to change your social environment. And then when they start explaining to you, yeah, let's talk about how easy that is. And they start talking about the different delivery systems, how they're doing it, where they're getting access to it. Then you have to is a wrong way to say it. It's important that we may be willing to make the changes necessary to keep up with this quick changing trend that we have in dealing with substance use disorders. I find myself doing more and more trainings now than I did in the beginning of my career because it's hard to keep up. It's progressing quickly. So the brief negotiated interview, when you learn SBIRT, has an actual algorithm. It's 4 steps. You build rapport, and in building rapport, you raise the subject, you explore the pros and cons of use. In motivational interviewing, and that what you're really doing is trying to develop discrepancy. And it's done through just a questioning process and having a discussion about what the actual patient wants to talk about. And it was talked about this morning. I've had, in Louisiana, I could say South Louisiana, with some of the patients, one of the most common things where we start off with is employment. You know, there's a limitation on what you can do for work when you're actively using substances. And most often I'll hear, you know, that's not the only thing that they will say that, you know, and if I could just be able to better take care of myself, or if I could maybe get that good job, as they might call it, because they have these other things they call weed jobs or drug jobs. What are your drug jobs in South Louisiana? Fast food, cash jobs, washing cars, cutting grass, construction. So construction, farming, landscaping, there's certain things, there's a certain group of jobs that is not going to get drug tested. It's a lot of manual labor, a lot of things going on. When you talk to them, they'll say, like, you know, I think I could get a job at so-and-so, but I can't pass a drug test. Oh, well, great. So maybe we can work together to be able to get you to pass a drug test so that you can get that job. Not really focusing as much on the addiction at that point, is focusing on what they feel is important. And as you use motivational interviewing, it's going to be different with every client. Sometimes it's the family, sometimes it's friends, and sometimes I had a recent case where it surprised me, and the person said, yeah, I'm just tired of sleeping in my truck. Nobody knew. You know, they owned their property, it was some family property, they were parking out there, lights were off, they had been sleeping in their truck. So what do you think became the goal? For them to be able to sleep somewhere else in a bed, not in their truck. May seem like that has nothing to do with their actual opiate use disorder, but it has everything to do with it. What is preventing them from being able to get out of that truck? All right. How much do you think it cost them to get the lights on that property? Somebody says a couple hundred. It was $50. They had an RV on the property as well, $50. But when they're making those decisions to continue on with the substance use, could not hold on enough to the $50 to get themselves what they needed. So when we're looking at making those referrals and working with these clients, I was probably the fifth or sixth person they talked to where they finally said, I'm sleeping in my truck. Why? It's because this stuff works. I don't come to present on this because I think it's a good idea and I think it's something nice for you guys to know. I've been using it now for a solid 10 years and it works. This brief negotiated interview, and there's another thing where we implement, which is just really, I learned that working with EAP, you got 6 sessions. In 6 sessions, you have to make miracles happen. So I was trained to learn a way to effectively bring rapid change with 6 sessions. And that's not because I wanted to do so. If not, that was what the client had that they would pay for. So it's adapting to see what's needed to be able to work well with the patient. So second thing, you want to provide feedback. You want to build readiness to change. He demonstrated by the readiness ruler on a scale of 1 to 10, how ready are you to make some changes as far as with getting out of the truck. Okay, they say a 5. You know, the thing is not saying why you're not a 10. So good, well tell me about the things, and this is change talk. This is self-efficacy. It's the things that they believe in about themselves. When we engage these patients, do they know they have a problem? Yeah. So reinforcing that they have a problem, how much benefit are we giving them? But when you're eliciting this change talk and say, you know, you see you chose a 5 rather than a 4, so, you know, tell me why you chose a 5. You're then getting to dig in and see about the things that they consider to be positive about themselves, and you can start to pull on those things. You're more likely to get something they're willing to work on out of asking them about their strengths as compared to pointing out the 10 problems you already know that they have. It's a little weird when you first start doing it. There's plenty of training on motivational interviewing online. There's a lot of stuff in the public domain because a lot of grants have been used for this. Expert, the same thing. A quick Google search, you will find plenty of reputable trainings that'll cost you nothing as far as to get acclimated to this. The most important part is negotiating a plan for change. Of course, you can get to that point, and sometimes that negotiating a plan for change in that doctor's office or the federally qualified health center, in your addiction treatment center. It could be you as a nurse on a home health visit. whatever the context. It may just be for them saying, I'm going to try to do better. And the next time you get to see him, say, well, man, great, I want to hear what you did and how much it was better. If in their heart they're ready to start making some changes, which most of them are, they're going to now want to have that conversation with you. They might not have been willing to accept the referral, even want to go in that direction that first time. But many people, when you talk to them, they give you this extensive use history. Then you ask them the question, have you ever tried to stop? I get a lot of people I work with that say no. So in their minds, when you ask them, can you stop, what do they think? Yes, I can. I can stop. I just never tried. I did it because I wanted to. Then when you go back and you make that second round, then you're talking to them and they're saying like, yeah, you know what, I tried. It's not what I thought. Good, well, what do you think you need? And you go on to let them have a lot of collaboration on what happens next. So it's very collaborative with the spirit of MI. It's non-confrontational. It's evocative, meaning that it's questioning, like rowing your oars. It's open-ended questions, affirmations, reflections, and summaries. You reflect back to the client what they're saying. You're asking open-ended questions rather than, do you know you have a problem? So what do you think is causing you some challenges right now? Then you give them an affirmation. I hear that you're having problems with such and such. It's important. You can affirm what they're saying. You might reflect some feeling, reflect some meaning. And at the end of the conversation, you give them a summary. Here's the most important feedback that I get on a regular basis is that they feel like they've been given a voice. If you can effectively do that summary and been listening, and now it's a voice given back to them of what they're struggling with, there's a connection that happens. They're usually a lot more likely to want to make some change. It's very respectful of autonomy. It's questioning to ask them what they want to do as compared to, I'm going to diagnose you and see your problem and tell you what you need to do. We're going to talk about this together and see what the challenges are. And I'm going to ask you, how can we make this happen for what you want to accomplish? And it's compassionate. Now, I found that in doing this, one of the, I'd say, unintended consequences, but it's still good, is that you want to talk about take a lot of pressure on themselves when they can't accomplish that goal that they set, because it's their goal. It's not your goal. It's okay. They can kind of say, it's no big deal. That's what you wanted me to do. I couldn't do it. When they start struggling because they came up with the goal, they felt that they could do it, and they realized that I couldn't do it. Second, another point that I want to make with that is, in dealing with the spirit of MI, is self-efficacy. Is the client, the patient, believing that they can do it? Because they can often tell you, yeah, I know 10 things that I can do, or that can be done, to better put it. Well, great. And so, you kind of get in the conversation about how they can do those things, and they say, oh, no, that might work for everybody else. I'm not saying that it can work for me. So building self-efficacy within the actual patient is very important, because it's not, sometimes you feel like they can change, but they don't quite believe that. And so it's walking them through a process so they can come into agreement with that. All right, so the principles in MI that are part of the brief negotiated interview is that we express empathy, it supports self-efficacy, it rolls with resistance, and develops discrepancy. Developing discrepancy is always fun. They will try to put forth their best self, tell you information. If you're accurately and effectively doing the reflections and doing the summaries, eventually you come to a certain point to where, well, I know you mentioned that the best place for you to go stay that you just said would be your aunt's house, but you also told me a few minutes ago is your aunt's house is the place where you actively do the drugs. How's that going to work? And then you might have some, but you're in a place to where you're not developing discrepancy based on what you thought about them. It's just you're just getting a chance to reflect back to them the discrepancies that they brought up. And you'll see it's very non-confrontational, because they have to sit back and look. It's like, that don't even make sense to me. You might even get that response. I don't even know. Mr. Wynn, I don't know what to tell you, because it don't make sense to me either. So enroll with the resistance. And some of them will come. I have clients, and you guys, if you're working with opiate use disorders or just addiction in general, some clients will just test you. And It's not part of the presentation today, but dealing with adverse childhood experiences and that crosswalk of dealing with personality disorders, clients with addiction and post-traumatic stress disorder, avoidance is avoidance, right? That lack of empathy looks the same whether you have a personality disorder client, an avoidant client with trauma, or a client who's just kind of disconnected from actively using. It's taking the time and working through that process. We do that as professionals, but often society will label them quickly. You know, it's real simple for some in the criminal justice system to, through the interviews, to really be able to write somebody off, because at the point when they're doing that, when they're actively engaged in the behaviors they've been engaging in order to support that addiction, it does look like they don't care. But that's not the case. So screening stratifies risk and specifies level of intervention. So what we hope with the SBIRT model, not as much with the LeSueur project, but also speaking to the overall, what the state of Louisiana wants, is to see this implemented in all primary healthcare places. You know, it's a public health model. And if everybody's screening and assessing and making referrals, if you can start doing brief negotiated interviews, which might take you 5 minutes, just imagine what kind of impact you can have with people who never move up the scale to have that mild to moderate substance use disorder. We had a weird anomaly that we tracked, and we couldn't figure out what had happened when we had stopped doing drug screens at one point, and the rate of failure in this program we were offering went up tremendously. And we sat back and looked back, we started looking as a team, thinking about it. We didn't realize that we were implementing that even when a person came in for a drug screen. When they came in, the receptionist was using motivational interviewing strategies. When they walked to the back, the person collecting the urine drug screen was doing what? In that 5 minutes of doing the collections and everything, if there's a brief intervention, what are you doing? Doing that brief intervention. So every time they came for a drug screen, even though they were no longer getting any actual specialized services, it actually helped to keep them sober. There wasn't a plan, but it was something we looked at afterwards. We didn't notice it until we noticed a great decline, implemented it back, and we've seen good outcomes. It's things like that you think don't matter. And when you go back and you look at the data rather than just a subjective view of it, you say, man, just treating them with respect and having that accountability for drug screens created better outcomes for this patient. All right, so medication-assisted treatment can be used to reduce cravings and withdrawal symptoms, block the neurological pathways that produce the high, and induce negative reactions when the substance is taken. I was at a national conference, and the intervention that worked for me to really kind of remove my the stigma and really to embrace medication-assisted treatment. You know, I asked a question at a conference, and it was one of the leaders in the field. He was like, well, I asked him, I said, what about with them with something like buprenorphine and them abusing it? And he gave a similar response like what was brought up about the ADHD earlier today. If a client doesn't meet the criteria, you give them the stimulants, what's going to happen? They can abuse it, they have a certain effect. Most of the clients I work with that are young and it was effective, they didn't want to take it because it made them feel like, lethargic, but they would talk about it, they felt like a zombie. Young boys talked about, I can't gain weight. I'm in high school, I can't bulk up. Everybody else is bulking up. So with an appropriate diagnosis and appropriate medication, it's not as much of an issue. And he brought up this point. He was like, this is what I can tell you. If a person has been using heroin at the level that they're reporting to you, and they have built up that type of tolerance, they will not be able to get high on buprenorphine. And I was like, Now, I'm not a doctor, not a prescriber. I've had a conversation with a couple of others, and there's some points with that. And he was like, but most have confirmed it's a very similar thing. Now, do you want to just give it to everybody? No, that's where the clinicians and the doctors make that decision. But just like the ADHD medication, will you have some people who may be prescribed it that they're getting the stimulant effect? You know, there are those things. But before then, you heard so much more about the fact that it's just trading one for another. And part of medication-assisted treatment is a harm reduction model. Not all of us are going to agree about philosophy of treatment. It's just a fact, you know. But what began to change my mind, let a few of your clients die, and you might start thinking a little different. It's unfortunate that something so dramatic had to happen, but we started losing clients. Losing clients because they didn't have access to certain types of treatment. So I'm not going to beat a dead horse with that. We've heard a lot about that. So guidelines for a successful referral, we follow the B&I algorithm. It's really important to do a warm handoff in making referrals. Sometimes in referrals, it's about giving them a resource and then say, hey, can you go contact so-and-so? It's been proven to have better outcomes if you actively participate in the referral and maybe even connect that person directly with the referral source, set up the next thing, and then you put them in the hands of the other person. And then you determine how interim communication will occur. And what we'll be doing as SCAT teams is like, well, they're coming on a regular basis to the OBOT for their medications. Well, if referrals are being made, warm handoffs, you get releases of information, that type of thing, you can work with those recovery support services to ensure that that person is getting all of the help that they need. But just giving them a piece of paper and say contact so-and-so, there's a good chance that it may not happen. Not to mention, again, like we talked about the thing with someone sleeping in their truck. You know, you may not have all the information as of yet of why, but if you're doing the warm handoff, there's a lot more information if you continue to do motivational interviewing, starts coming out as you're making the referral. I had one person who was was riding a bike from Dusson to Lafayette to come to the clinic. Had no idea they had moved out of their house and went somewhere else. That is pretty extreme, 3 days a week on a bike. Then doing other appointments and then riding the bike back. And if they're in the criminal justice system, you got to be careful. Because if they miss something, they might get sanctioned, go to jail because they were just tired from riding the bike. But nobody knew the transportation issue. Once the transportation issue comes up, it's like, you're showing up kind of disheveled. I mean, is everything okay? I just rode 15 miles on a bike. It's like, yeah, I'd be disheveled too. I mean, first of all, I don't know if I could actually do that too well right now. 5 years ago, 10 years ago, maybe. Right now, I'd be struggling. A warm handoff is more effective than a passive referral. And you want to clarify the expectations for follow-up with the patient at the time of referral. You want a valid release of information and look for regular update about the patient's progress. And really it's about when you're having that conversation, you're reflecting back to them, reflecting the feeling, looking at reflection of meaning. If you truly are walking alongside them to get help and you're letting them know you're going to check up, when you're going to check in at 30 days, guess what? Check in. How'd it go? You know, is there any challenges? You know, when we send people to certain places, not every place works for everybody. Well, good. It doesn't have to mean that there's anything negative about that particular place. Well, now you notice what doesn't work or kind of like what you don't want. Can we have a little bit of conversation what you think would be better, now that you have something to compare it to? And you work to make a more appropriate referral so we can get them engaged. The old style, when I first got involved with addiction, that would have been a very directive approach to get on them about why they didn't comply. Compliance, compliance, compliance. Then you find out, well, no, the guy who used to sell me heroin was at the place. Yeah, so I'm not going. You told me not to use heroin. So you get in this whole big thing, it's like, wow, if I just asked. But that's not where the training was at that time. The training was, we were the experts, right? And you had to guide them. Now, with this model, with motivational interviewing, who's the expert? They're the expert of their own life. You're just using the skill to gather the information you need to help them get to where they want to be. The hardest part of the job is finding out what that is. Because to be sitting in front of you, they have to have at least some desire or to change, even if it's just because to make their girlfriend or their mom or somebody happy. There's some type of desire. Use that. That's why they showed up. Structured discharge plan with aftercare is definitely recommended. I'm not going to stay too much on that because there's a couple of things I want to touch on as I bring this to a close. Biopsychosocial model is something that was talked about this morning. Does the patient have a chronic medical condition? Will the chronic medical condition interfere with their current level of care? Is the patient receiving care for the chronic medical condition? These are the kind of biological things that you're looking to try to find out. And I'm going to go through these quickly, but I think they're going to be able to make the slides available to you guys. Psychological, does the patient have a co-occurring disorder? How will this impact the patient's ability to receive treatment? Is the patient receiving mental health management in any type of way? And is the person that they're receiving it from willing to collaborate with you? That becomes a real issue. Does the patient have a car? Can they access public transportation? How available are the drugs or alcohol in the home? These are things that we're familiar with doing, and I want to spend the time on this last slide, and this is really about here. There is still a stigma associated with medication-assisted treatment. And when you start looking at making those particular referrals, as you go up on Maslow's hierarchy of needs, is not quite as bad in some ways. But let's talk about at the bottom, dealing with a person that's pregnant. You have a very limited amount of resources in the past, but I can say when we first did the slides a couple of years ago, now it's not as much of an issue. I could probably take that pregnancy and move it up a little bit higher. There was just very little access to what you can do. They have medication needs, alcohol and drug testing, medical service, ambulatory detox. And that's the thing, what's also nice about the detoxification services, but yet if somebody is appropriate for medication-assisted treatment, you don't have to take them out of their environment. Because when you do a good assessment and doing a level of care, which might have been different with the paths to opiate use disorder are not the same like what you might see with certain other substances. That person may have a lot of good social supports, a lot of strengths, a good home environment, and when you're using medication-assisted treatment, you're less likely to have to take them out of that environment. You can actually work with the family and allow that environment to help them to do better. You know, some years ago, if somebody presented with the same thing, what was our option? You know, treatment in a halfway house? Maybe sober living after that? Let's count the months. 1 month plus 6 months plus 3 months. 10 months away from family. And for a lot of individuals, when you look at the majority of who we were dealing with, they had some serious issues. Family were done, things were happening. But that rapid onset of the opiate use disorder, often the family's not done. They're in my office just lost, trying to figure out what do we do. But they're there to support them to see what they need to do. So again, assessing what's going on and seeing that with medication-assisted treatment, you can probably prevent some of those actual inpatient stays. Making decisions about employment, housing, counseling. You got the public health, public safety thing. And on the legal side, if they're on probation, understand that, you know, it may be very important for you as the professional to contact the person that's directly supervising them, because they're not going to have that much of a voice when they're under supervision. It's a lot more important for you to contact that person directly. With all of these, you know, we're professionals in the room, but just want to go over looking at when a person's presenting with an opiate use disorder, actively using heroin, a lot of issues, potential for withdrawal. We starting off there. What do we have to do to stabilize and go from there? Is the thing I would like to talk more about is closing is that the stigma and the philosophy of the treatment. I'm hoping that the more that we're doing this around the state and around the country, that we continue to see the good progress that we're making. I feel the same way as Scott feels. We're making some pretty rapid improvement as far as in reducing this stigma for people that are on medication-assisted treatment. I can tell you 3 years ago, it would have been extremely difficult for me to make some referrals. Now it's not so much. Availability of services have really increased. We're having a lot of good community discussion about it. It's not that everybody's going to have or agree with that philosophy of treatment, but there is enough information out there and enough willingness that we can give these people a better chance. Last thing I wanted to say is that I'll leave this slide up when we finish. This particular website, just got this email this morning that actually will link for you to be able to see where the actual contracted OBOTs are in the state of Louisiana. That way, if you want to make a referral, there are some things worked out to help get them access to medication-assisted treatment. And just in closing, anybody who's familiar with that, it can be extremely expensive on private pay to do so. What this is doing is opening up people to get services that can't afford to pay for it. But with the LASOR grant, it's opening up access to some other individuals. We have one person in Region 4 so far, but we have 2 more that are closely in progress in a lot of the other regions. So when you look at this website, it won't just have this area. It'll be all of the OBOTs within the state of Louisiana. All right. Thank you.